Happy Friday. I'm going to go ahead and get started. I have a lot of content in a short amount of time. So I have no disclosures. The genitourinary component makes approximately 5% of the exam. So here's the objectives that we'll go through today. So we'll start with GU tract conditions and bladder disorders. So incontinence is the involuntary loss of urine. According to the American Urologic Association, 1/3 of Americans over the age of 40 report some level of incontinence. This is more common in females as compared to males. However, the gender disparity does narrow after the age of 85. This can cause a significant impact on quality of life, including skin irritation, pressure ulcers, falls, social isolation, and depression. When you evaluate a patient in your office for incontinence, you want to get a good history physical evaluation. So things you want to learn from that patient: what are the precipitating factors? Does the incontinence start because of coughing, laughing, lifting, sneezing, straining? Is there a worsening with intake such as alcohol intake, caffeine? Is that patient constipated? Does that patient have immobility issues? You want to understand the severity of the leakage, how many pads, and how wet are those pads. You want to understand other urinary issues. Is there urgency, frequency, nocturia? How is the stream? Is there hesitancy? Understand the OB history in females. Is there other GU conditions in terms of their history? Is there history of stricture, diverticulum? That can be urethral diverticulum or bladder diverticulum. Sexually transmitted infections, history of urinary tract infections. Get a good history of pelvic surgeries. Is there neurologic disease? Does that patient have MS, stroke, Parkinson's? You want to understand their fluid consumption and their medications. So stress incontinence is a leakage that is associated with increased abdominal pressure. So occurs with coughing, laughing, lifting, sneezing. This is caused due to urethral hypermobility and a lax pelvic floor musculature. Risk factors of stress incontinence with increased age, the race, obesity, diet, smoking, damage to the pelvic floor during pregnancy and childbirth for women, and after prostatectomy or pelvic surgery in men. Treatment of stress incontinence, bladder training. You want to make sure that patient is voiding in a timely fashion. Pelvic floor exercises. Consider a pessary or vaginal insert. Surgery with bulking agents, urethral slings, or urethral suspension if it's severe. The degree of leakage and how it impacts the patient will often determine the aggressiveness of treatment. So you want to ask that patient, what does it keep you from doing? Overflow incontinence is when the bladder does not empty properly. The urine production exceeds storage capacity. So poor bladder emptying occurs if there's an obstruction, those men with enlarged prostates, if there's history of urethral stricture, if there's prolapse in females, or if the bladder muscle itself cannot contract effectively, which is detrusor dysfunction, which can be idiopathic or neurologic in etiology. So to treat overflow incontinence, you need to empty the bladder. So that can be done via augmented voiding techniques with double voiding or putting pressure on that suprapubic area called Crede. You can consider intermittent versus indwelling catheter. Surgical correction if there is evidence of obstruction or stricture. There's no medications that will make that bladder contract better. Urge incontinence is common. It affects more than 33 million adults in the United States. The symptoms include strong urge to void that cannot be controlled. This can be with or without leakage. Usually there's no other pathology. Risk factors: age, menopause. There could be a neurogenic component, history of MS, stroke, brain issues, and BPH. So functional incontinence is due to underlying mental or physical impairment that prevents the patient from making it to the bathroom. That can be due to mobility issues from obesity or arthritis, can be due to cognitive dysfunction or history of traumatic brain injury. That can also be due to psychologic factors or depression. The treatment is timed voids or encouraging absorbency garments. Mixed incontinence is when an individual has more than one type of incontinence. So when you evaluate somebody with incontinence, you want to get a urinalysis, voiding diary, a uroflow with ultrasound residual. In men, you want to examine with a genitourinary exam, digital rectal exam. Females, you want to get a pelvic exam. And what are you looking for? So with females, you want to evaluate for stress incontinence. You may need to not only examine for stress incontinence in the supine position, but sometimes women will leak more so in the standing position and not in the supine position. So you want to do an exam in both. You want to assess for vaginal atrophy. You want to assess for that patient's ability to recruit the pelvic floor muscles at the time of the exam, and how well can they do Kegels on their own. You want to evaluate for pelvic floor tension, pelvic organ prolapse, and you want to rule out any additional etiology, including urethral mass or urethral diverticulum. So in treatment, the first line is generally behavioral. Just understanding and teaching the patient what normal bladder capacity is, normal function, make sure they're voiding in a timely fashion. Understanding fluid schedules, managing constipation, because there's definitely a correlation between those patients who have difficulty passing stool and difficulty voiding. You want to consider biofeedback to help with urge suppression, pelvic floor physical therapy to help with stress incontinence and urge incontinence. Weight loss can certainly improve incontinence as well. Medications are the anticholinergic medications, the beta-3 agonists. Percutaneous tibial nerve stimulation is an alternative option, which has similar efficacy to overactive bladders. It has minimal side effects. So this is done once a week for 12 weeks and then monthly thereafter for maintenance. Consider Botox into the bladder or sacral neuromodulation. So moving on to prolapse, it is the downward descent of female pelvic organs, including the bladder, uterus, post-hysterectomy vaginal cuff, and or small and large bowel. So anterior compartment prolapse is weakness in the anterior vaginal wall. It's a descent of the bladder. Posterior compartment prolapse is weakness of the posterior vaginal, often associated with bulging of the rectum, which is the rectocele. So risk factors. Parity or and obstetrical history certainly is a risk because of vaginal delivery. Forceps may further increase the risk of prolapse. Obesity is not only a risk factor, but is associated with early recurrence of prolapse if repair has been done. Advancing age, the prevalence of prolapse increases by 40% with each decade of life and peaks around in the 70s. Hysterectomy history is a risk factor. Smoking, chronic constipation due to the strain, and ethnicity. It's more common in Caucasians and Hispanic women. So symptoms of prolapse include pressure and heaviness of the pelvis, a sensation or feeling a bulge, low back pain, bleeding from eroded vaginal mucosa, voiding symptoms or sensation of incomplete emptying, straining or needing to change position to empty the bladder, discomfort with sexual activity. Bowel symptoms are generally not correlated. When you evaluate for prolapse, you want to get a physical exam, get a voiding diary just to understand intake of fluids and output. You want to get post-void residual by ultrasound. If there's concern of bladder dysfunction itself, you want to get a urodynamic study. In postmenopausal women with vaginal bleeding in the absence of physical exam findings to suggest ulceration of cervix or vagina, you want to evaluate the endometrium. In patients with advanced prolapse, you want to also evaluate the upper tracts to make sure that the ureters are not obstructed, causing hydronephrosis. So staging of prolapse, stage 0 is no prolapse. Stage 1 is more than 1 centimeter above the hymen. Stage 2 within plus or minus 1 centimeter to the hymenal plane. Stage 3 is greater than 1 centimeter, and stage 4 is complete vaginal eversion. So here's a picture of the various prolapse. So the first one is cystocele. You can see the bladders coming down. The middle picture is the, I don't know if you can see my cursor, but you can see the rectum prolapse. And the third is the enterocele. That's the bowel protruding there. So prolapse management. So the degree of bother is key. You want to take a patient-centered approach with the patient in management. You want to consider the anatomic defect that they have, the effect on organ function, the severity of symptoms, and the impact on quality of life, their desire for sexual function, and patient preference. So treatment begins with education. If patient has excessive stress of the pelvic floor because of heavy lifting, chronic constipation, or cough, you want to make sure that that is corrected initially. Weight loss and smoking cessation for those patients indicated. Symptoms of vaginal atrophy should be treated with topical estrogen if there's no contraindications. So non-surgical interventions include pelvic floor training, either self-directed or at the guidance of a therapist. This is usually done as an initial approach for stages 1 through 3 prolapse. Consider pessary for those patients who are significantly bothered by their prolapse but don't want surgery, aren't medically fit for surgery, or plan to have additional children. Surgery is indicated if the woman has significant bother and wishes definitive treatment. This should only be done after childbearing is complete and after the patient had adequate conservative measure trial. Reconstructive procedures aim at restoring normal anatomy and function of the vaginal canal. So there's anterior and posterior approaches that can be with or without hysterectomy. Patients may also need a sling. There's obliterative surgeries that will result in permanent and irreversible closure of the vagina.